Hi, I'm Dr. Dai Chung, Chief Medical Officer of the Joint Pediatric Enterprise between UT Southwestern and Children's Health. Welcome to this new segment of the In the Know video series. In these videos, I'll sit down with various physicians to shine a light on the clinical excellence, innovation, and medical advancements that are happening across our enterprise. I look very much forward to sharing this incredible work of our colleagues to transform pediatric healthcare in North Texas and beyond. Here we have Dr. Samir Pandya, who's an Associate Professor of Surgery in the Department of Surgery, Division of Pediatric Surgery at UT Southwestern and Children's Health. Tell us about your program in general, pediatric surgery.
So we have a very robust and clinically busy program. We have providers with a wide, varied experience, whether it be for open surgery, minimally invasive surgery, tumor surgery, any kind of intestinal surgery, thoracic surgery. I like to look at our division and say that we perform surgery of skin and its contents. Like anything in the body, we're it.
So it sounds very broad.
It is.
And even the sound of pediatric surgery sounds like it could be anything. So what does it take to become a pediatric surgeon? And is it a special and unique specialty?
That's a great question. What many people don't realize is that all pediatric surgeons start off as adult general surgeons. So you have to go through medical school, become an adult general surgeon, become board certified in adult general surgery. And then often you have to do a couple of years of research and then 2 more years of dedicated specialized training in pediatric patients specifically. So that whole journey can take anywhere from 7 to 9 to 10 years for some. So a decade of their life after medical school.
That just seems like a long training. Give us some examples of what pediatric surgeons do commonly in the hospital.
The role of the pediatric surgeon is to really care for all the surgical aspects of the patients, of the pediatric patients, whether it be newborn all the way to 18 or even older. And we're also the critical care surgeons to provide ECMO, which is, as you know, is extracorporeal life support. So what we like to tell our trainees is that when they get a call as their first call for a consultation, the answer is yes. Just we'll figure out who needs to do what, but just the answer is yes.
So is there any particular sort of focus that you kind of concentrate and the so-called your expertise or niche?
Yeah, so I would say that I'm known for minimally invasive techniques, and that is anything from using smaller laparoscopic instruments, which are like little chopsticks that we use to do big operations with, to doing it all through one single incision in the belly button, or even robotics. And we do this in the chest and the belly. And we could do it for benign conditions as well as malignant conditions. So that's what I am known for, I would say. That said, our entire division performs minimally invasive surgery. And one thing that I'd like to highlight that a lot of people don't realize is that across the nation, I would say that we're in the top tier of minimally invasive surgery in pediatrics at this point.
Give us some of the real advanced minimally invasive surgery in pediatric surgery.
Oh yeah. So I would say like one of the most advanced things that we do is there's a condition called esophageal atresia, in which the esophagus is not connected and you have to put it back together. So the esophagus in these babies is about a centimeter in diameter at most. And we are able to reconnect the 2 ends of the esophagus in a 1 centimeter diameter tube and put 8 stitches in them, and all with tiny, tiny chopstick type of instruments. So that the child, when they grow up, they don't have any memory, whether it be through a visible scar or through repeated operations of having had that surgery. Patients who undergo minimally invasive surgery, we know that there's data that shows that they have lower length of stay, they have lower need of opioids. As you know, we're in an opioid epidemic, and they have better cosmetic results from a scar standpoint. I have 3 daughters myself, and I constantly think about who's going to do their surgery if they need them, and if they do, are they going to do it minimally invasively? So that's how I'd like to treat the rest of the patients.
Great. Tell us, or if you can share with us, one of the most sort of memorable patient experience or the challenging conditions that you are able to help with infant or child. Or I wonder if you can kind of, so that audience can kind of have that much better sense of what you really do.
This is a baby that was transferred to us here, and this baby was born with 2 things. There's esophageal atresia as well as duodenal atresia, which is part of the intestine. The first part of the intestine was not connected. So for that baby, we're able to fix the esophagus minimally invasively, and then flip the baby, and then do the abdominal part also minimally invasively, all in one sitting. So after all of that, the baby's gonna have like 3, 4 tiny little incisions, and has had 2 major operations, one in the chest cavity and one in the abdominal cavity, all in one setting.
What should our community of physicians and staff and employee should know better or more about what pediatric surgeons provide at our hospital?
We're here, we're available, and we're able. And we would much rather that everybody calls and asks us what can be done, rather than make the assumption that we won't do it. That's the message that I'd want for them to realize.
Great. What's in the near future for the program or division or innovative parts or aspects of the program that we should be aware of?
We are looking at kind of standardization of some of our protocols, and looking at making sure that we can make it easier for all the providers in the hospital system to recognize how patients are going through the system. We're also looking at different programs for early recovery after surgery, in which we reduce all the opioid requirements and are more intentional about how we're treating their pain and how we're trying to get them to recover after the patients to recover after surgery and get home quicker. One thing that people don't realize that is we were one of the first institutions to publish large series on same-day discharges for several conditions that we do. And there are still several places that admit patients overnight for patients that we are able to get them through the system by the same day. So we're constantly tweaking that and reevaluating what our outcomes are. So I think those are a couple of things that are coming down the pike.